I'm not upset that somebody did this. I am personally very hurt because I know all of you, and I'm disappointed that this happened. And I gave thought to posting a guard outside the door to make sure that nobody overheard our closed session conversations in the future. And I thought that I really don't need to do that with this group of dedicated employees. I think hopefully it was just a not understanding how serious our job is as board members. So I would like to ask all of you to honor an honor code and commit to not standing outside here when we're in closed session. If you can hear the conversation, you need to move to another area. And I hope everybody can abide by that. That's all I have to say about that.
Can I make a comment?
Yes.
That deals with that. I think it's a fairly egregious situation, and I would like to make sure that we agendize this for a closed session for further discussion with Linda Wagner.
Okay, we can do that. The second thing I wanted to discuss briefly is that I like to be well prepared. I think this is a responsible position being on the board, and I don't like to come to board meetings unprepared. And I set aside all day Thursday to review the information so that I can run a meeting. Unfortunately, this week, things have come up, extenuating circumstances that have required a tremendous commitment of my time, and I'm not as prepared as I would normally be for this meeting. So if I stumble a little, please forgive me, and board members feel free to correct me if I make mistakes. With that, I will open the meeting to public comment. It's pretty quiet. No public comment, we'll move on. We have guest speakers. Linda, would you like to introduce them?
Yes, we have T. Abrams from Regional. He's the Regional Vice President, North Bay Sierra, Redwood Coast. I'm reading this. Hospital Council, Northern Central California. CHA, California Hospital Association. And we have Ryan Witt. Did I say it right? Yes. California Hospital Association's Vice President of Healthcare Financing Initiatives. Ryan is previous from state, and he is the IGT guru. So if you have IGT questions, he's the man to ask. So go ahead.
Well, maybe I'll start a little bit. I don't know how much you all know in terms of CHA and the hospital council, who we are and what our role is, but virtually every hospital, there's a handful of them that aren't, but virtually every hospital in the state of California is a member. And they pay member dues, and as a result, you are a member of the California Hospital Association and the Hospital Council of Northern California. You also benefit from what goes on elsewhere in the state, because when you pay dues, you pay one set of dues and you get access to everything. And fortunately, while they're separate organizations, these regional organizations and CHA, we all work very closely together. I'm with the Hospital Council, Ryan's with CHA. This is a perfect example. We're frequently in the same room together. We're frequently working together on things. So what do we do for you? There's mainly three things. There's a ton of things, but it really falls into three buckets. And one is advocacy, one is convening, and one is education. And when I say convening, we are getting together hospital people, but sometimes we might get together hospital people and state people, and we might get together Medicare people, or we might get together hospitals in the counties, but we'll do convenings to have collaborative types of efforts. The other thing we do is education. Healthcare is going really, really fast. It's incredibly complex. It's incredibly political. There are new regs constantly that are taking place. We have staff that do nothing but monitor regs in DC and Sacramento. And we have lobbyists and all kinds of people, and there's constant change. I frankly don't think hospitals can keep up with them. there's just too much coming too fast, and the only prayer you have is our organizations do a ton of education. So we're routinely doing webinars, we're publishing information, we're the authors of your compliance manual, and on and on and on for things that are established and things that are new and that are coming. The other thing is, so advocacy, education, and on the advocacy side, let me back up a second. The CHA, well, anyway, I said those three things. The big difference is that with the regional associations, hospital council, we're kind of the local arm. CHA does those three activities at a federal level, at a state level. We do it more at the local level. So while CHA is doing those kinds of activities with Medicare and Medi-Cal and the state legislature and others, people like me on the ground are doing it more with boards of supervisors and mayors, and we're actually the front lines for CHA. We're feeding information up to CHA to keep them relevant. And so the area I serve for the hospital council, I serve 18 counties, 45 hospitals, from Marin County to the Oregon border, from Plymouth County to the Oregon border, and from the Pacific Ocean to the Nevada border. And so I'm doing convenings, and I'm doing education, and I'm doing advocacy, and then CHA is as well. It so happens that Ryan and I are on a road trip. We visited a couple hospitals, and we had a convening in Reading yesterday where we had about 20 people in the room. And as a result of that gathering, and that I could bring that many people together, I was able to bring the CHA expert on the IGT. And Ryan is fairly new to the California Hospital Association. He came from the state, and he was very involved with the IGT program and the hospital fee program. They're very similar in many ways, a little bit of difference. But he ran it for the state. Well, we were lucky enough to hire him away from the state, and now he runs it for CHA. So the perspective he has is unbelievable. And fortunately, because of the meeting in Reading, I was able to get him to come with me here. And so you're getting access to him that others have not had, and if you have questions around the IGT, he's always available. It's not like he's going to disappear. You can always call if you have questions. He's a resource. He can get on a con call with you, but there just aren't going to be many times where he's in the room with you where you can really kind of quiz him on the IGT. And I know I'll stop there and leave it. There's changes coming to the IGT. Some of them significant, and Ryan can talk about those, but I would encourage you to be candid if you have questions, if you have ideas, if you're wondering why it works or why it does this or why it does that. He's about as good as you're ever going to get. So I'll leave it at that.
Thanks, T.
No pressure.
Yeah, seriously. So as T and Linda had mentioned, I recently joined CHA from in December from the California Department of Healthcare Services. I was the Assistant Deputy Director for Healthcare Financing in that role, where we were responsible for overseeing managed care rate setting, hospital financing. If you have a skilled nursing facility, I can help you out there as well. FQHC rate setting, RHC, so rural health clinic rate setting, any supplemental payment beyond just hospital-based or managed care. But the biggest changes in the landscape really that are forthcoming are in the managed care arena. And so Seneca today receives pretty much two direct supplemental payments in the managed care space. They get what's referred to as the state, and folks here probably know, is the SB 239 IGT, Intergovernmental Transfer. And it is viewed today from the federal government and the state as an allowable pass-through payment. In 2016, federal requirements changed the way how all Medicaid managed care is financed. And with that, with those significant changes, there was one major component which began to define supplemental payments, which is what this IGT arrangement is, as impermissible under the new rules beginning in state fiscal year 17-18 and moving forward subsequent years. However, the advocacy effort that California proposed throughout the entire regulatory process included a provision for a phase-out period of 10 years for any existing hospital supplemental payments that were in effect prior to state fiscal year 17-18. And those payments were at the threshold of an arbitrary date that the federal government set that was in effect as of July 6th of 2016. Now, the hospital fee program, which is not something that Seneca participates in today, it's where the private hospitals tax themselves to receive supplemental payments. You guys are considered a non-designated public hospital, NDPH. So you're viewed as pseudo-governmental entity, which is allowable to participate in intergovernmental transfers today. So you have an advantage there. But the hospital fee program is also, along with the public hospitals, the designated public hospitals, any hospital supplemental payment is going through these exact same changes, which are having to conform with the new rules that are passed down from the federal government. And the biggest change in how they defined it is that it must be for contracted services to network providers, and they must be for actual utilization. It can't be for historical utilization, which is pretty much what the hospital fee operates under, and it can't be for if you have uncompensated care that you can justify an intergovernmental transfer to draw down additional funds. They've ruled that as impermissible moving forward, beyond once the 10-year phase out is concluded. The space in which the NDPH IGT operates is still well within the pass-through bucket and is still not applicable to the phase down just yet. But on the horizon, those changes are coming. I would say within the next 3 to 5 years, you guys are going to have to consider changing, you along with every other NDPH, how that program will operate, how reimbursement will be received, because it will still be allowable in an intergovernmental transfer. You can still put up the non-federal share to receive the supplemental payments, but they cannot be for justifying uncompensated care to do the allowable directed payment. It will need to be tied to some form of utilization, some form of quality or value, as deemed permissible by the federal government. So those are the biggest changes there. And I understand you guys are in a regional model county for managed care, for Medicaid managed care. So that means you have 2 commercial entities that you contract with. But the definition of network provider, or the definition of being a network provider, to be eligible to receive these payments in the future, means that significant changes to your contracts are going to need to occur. And those will be going into effect as defined by the state in state fiscal year 1920. Being that you're not receiving directed payments for a few years, you have time to amend your contracts to conform to those changes, but that is not a lot of time. Is the messaging we gave yesterday to the others in the room, that if they're not quick to act and amend their contracts, they can kiss any supplemental payments on managed care goodbye. And to them, when they're being taxed, they're part of a broader program that is taxing themselves. They're still going to be subject to the tax, but they wouldn't receive any supplemental payments. So it was really a red alarm to them, because they needed to take it back to make these changes. Anthem, CHW, who are the 2 plans in your county, they're well aware of the requirements. The state has required them to amend their boilerplate contracts, and they've already gone through that process. Just this month is when they've received approval of those subcontractor boilerplates that meet all the new requirements. And so they should be going out to their network providers, the providers that they want to effectuate these changes with, to ensure they meet and conform to the new requirements. So I have a packet, and I can leave it with Linda, and I can circulate it to the group, of the actual contractual requirements that will be needed. You guys can evaluate it at your leisure.
Can you give me just like one example, just like, because there's 31 of them, right?
Yeah, so one of the requirements is, there's 31 specific, but one of them is modifying the records retention policy that you have in your contract, not from 5 years, which is the norm, to 10 years. Another one is must provide translation services, interpreter services. Another one is, shoot, there's a whole bunch of them. So you get the point. If that isn't specified and laid out in your contract, the state will not deem that as allowable, and we will not be permissible under the network provider definition. So we'll leave that information so that you guys have it. I will note that today you have also received intergovernmental transfer payments from the 1115 waiver, and that is under the PRIME program. Folks are familiar with that, where there's a delivery system reform event happening. That will conclude at the end of calendar year 2020. The state has no intention of renewing that program in the 1115 arena. Basically due to the fact that federal changes have occurred and there's no 1115 space to continue.
So what is Prime 2 then, that's bouncing around right now?
So I know
Sharita,
I'm sure Sharita's had conversations, but the future of that program will be modifying the existing structure and moving it into the managed care arena, which means you will be subject to these network provider requirements. Right, so today Prime doesn't have any of those requirements because it's not considered a managed care supplemental payment. The future of that program is modifying it and bringing into managed care, which is something that can conform, can bring in those additional supplemental payments, so there's not a loss, but you have to jump through these extra hoops to get them with the network provider definition.
Can I say,
It's a lot of technical.
In general, there's a move to try to go towards more risk-based managed care types of arrangements in order for you to get the money. The money will be there, but it's going to go through these new. They really want to get more outcomes-based. Their goal is to get more outcomes-based types of incentives rather than the structure that's been existing now. Is that a fair assessment?
Yeah, and historically there has been the focus in outcomes and quality. The state has always said that they value these programs because it keeps safety net providers afloat, right? And the state has always been well within their right to do so, to utilize non-federal shares that they don't have to be state general fund. They can be other governmental programs funding. They can be tax revenue if it's an allowable tax that the providers tax themselves. So they are well within their purview to do that. It's just now the delivery of the supplemental payments is where the federal government has changed it. And to T's point, they're trying to tie it to current utilization, current outcomes, health outcomes, and not focusing it on what would have been estimated losses from uncompensated care or backfilling things without getting something with their investment. So significant changes. It's not just California, it's every single state. This is that are dealing with it. During my time at the state, we met regularly with other Medicaid leaders, and we all had, sessions where we commiserated together and drafted, proposals on how we can continue these valuable programs moving forward and how we can alter it. And so, with the hospital fee program, they've already started. 17-18 was the first year where half of the $4 billion in the program is already conforming to these new requirements with directed payments. So the landscape has already changed for the private hospitals, the NDPHs. You guys are next, and you just had this lag time to get it started.
Can I get clarity too? I just want to make sure. Is the bucket growing or shrinking, or it's not a matter of growing or shrinking, it's just how you access the buckets of cash? It's not that they're growing or shrinking, it's just
Buckets
how
of
you...
cash.
Well,
No, I understand. It's supplemental payments will change. Medicaid, Medi-Cal enrollment is shrinking. Just put that out there. It's been shrinking since 2016. It may not be shrinking in Plumas, I'm not sure at that level, but in the aggregate space, statewide, it's declining. So to say it's a growing revenue source, I don't know that I would go that far, but I could say that it's still a stable revenue source. It just needs to be modified and changed to meet the new requirements.
and the hospitals need to change to, in order to meet those requirements, to still have access to those funds. Yeah.
Yes.
For those hospitals that you say have already adjusted to this, are they seeing a significant difference in income from the
They
changes?
don't know yet, actually. So state fiscal year 17-18 was the first year that these new requirements were permissible and subject to the directed payment program. The state, in its ability to mitigate as much of the swings as possible, negotiated with the federal government to have a pool payment, which meant all the money that was put up is going to be expended on hospital services. No managed care organizations that are going to take a break, no enrollment discrepancies. Everything is going to be expended on hospital services. The unfortunate thing is it'll be based on current utilization. So right now they're doing all the calculations to determine did it meet the projections initially, or will there be some variation of who are winners and who are losers. I would imagine that there will be some swings, unexpected swings, but it'll be dependent upon how quick they were to effectuate changes with their contract, and did their utilization, were there significant changes in utilization that is the reason for that. Those plans who worked best on conforming to changes, believe it or not, one of them was Anthem, and submitting information to the state in a timely manner. So I think you guys are in a good space there. You're a decent partner. It's just you kind of need to get the ball rolling, and it's the advantage is to be early to the table and to make the changes before everybody else does, because if they're not paying attention or they're asleep at the wheel, then again, like I had stated earlier, you can have all the utilization, and if you don't have a network provider contract, you're not going to get any payments.
And to that point about a good partner, last week, Ryan and I met with the president of Anthem Medicaid. He's new to the position, and he is very interested in building relationships with hospitals. There are 29 counties, and that's a tall order. He's come to us to say, would you help us to build, because we're in the hospitals, we're talking to the hospitals frequently. We know, Linda and I go to meetings, and I know Linda can pick up the phone and I can email her, and so he's asked us, can you help us build these relationships? And I agreed to help him, and I said, but I can't do all your counties at once. I can't do it. It's physically not possible. So we agreed the priority would be Plumas and Butte County. And he wants to meet soon, and I think it's in your interest to meet soon. And so I'm going to be reaching out to Linda to hopefully join the CEOs from down in Quincy and Portola and Butte County, Orchard Hospital, Emlo Medical Center. And we're going to sit down and meet with the president of Anthem, and we'll be talking about some of this stuff because he, to be simple, we need some stuff from him, and he needs some stuff from us, and it's time to start talking. So that'll be coming soon, and anybody hopefully will do that in the next couple of months. And the other thing that's interesting, I don't know where this conversation is going, he's interested in doing big initiatives with hospitals. He wants to do something collaborative, and I'm not sure what that means and what he means by that, but I like the sound of it. So we'll see what comes out of it. We'll see what the hospitals, this is where they can speak up and say this is what we need, or this is what matters to us, and maybe we can get some resources from Anthem that are beyond the kinds of things you just get out of a contract that are more, maybe it's amping up telemedicine, or maybe it's doing something around population health. I don't know. He didn't he threw a couple things on the table, but we'll see. We'll see what makes it work for the hospitals.
Anybody have any questions?
Can you get copies I'd like to see a copy of what he...
Sure.
If you'd like, it's up to you. I mean, I don't know. I know this happened last minute with us coming. If you'd like, if there's any other if you would like a legislative update, what's going on with the legislature, or if you have any questions, like I said, I serve 45 hospitals, and so and most of the rural hospitals in California are ones that I serve. So I know what's going on out there. I know what are hot issues. I know what are challenges. So I'm not sure if there's anything else. I mean,
What are the hot issues
in rural or statewide?
for us?
For you, probably the biggest, I would say, is workforce. That's probably the biggest issue facing the rurals. They just can't. They can't get employees, and unfortunately, let me go a little further, and Ryan actually has some good news on that.
Brought some nurses with us?
I'd say great news, okay? But the issue is so many of the rural areas are challenged in so many ways. So many of the places I go to, they weren't the places they once were in terms of their economy and such. And so you might be able to recruit a nurse, or you might be able to get the interest of a doctor. But the problem is they're frequently, not the problem, that's a terrible way to say it.
It is a problem.
The dynamic is that frequently you might get the doctor interested, you might get the CNO interested or whatever, but then their spouse or significant other comes, and if you're at that level, you tend to be married to someone else at that level, and they look around and go, what am I going to do? And then they go drive and look at the schools and say, this is where my kids are going to go to school, and then frequently, where's the Costco? And then the conversation falls apart. And even if you started to get some traction, Kaiser's out there offering $250,000 signing bonuses to physicians, and so I've even had, in the rural areas, I've had long-standing physicians leave rural areas. My own doctor, my doctor's in Placerville. My doctor, I just lost him last year. He's been my doctor for 15 years. He went to Kaiser, and that's happening in the rural areas. People are leaving very rural areas because $250,000. I mean, it's nothing to sneeze at. So, workforce is a big one. Seismic, the 2030 requirements. Oh, and it's not just physicians, it's nurses, it's everybody. It's trying to get anybody. I don't know if you're aware, Mayor's Memorial just closed their OB recently. I don't know if you knew that, but they had a wonderful OB program. We worked really hard to try to get them an exception with the state. We couldn't do it, and it wasn't because of physicians. They couldn't get OB nurses. And they had to shut down their OB program. We were just there today, and it's, they backfilled it with surge patients, med-surge patients and such, but still, they don't offer OB, which is terrible, and you know that they're still coming into the ED and delivering babies, so it's just unfortunate. But CDPH would not relax the standards for them, and so they had to close OB. And that wasn't a physician issue, it was a nursing issue. So anyway, it's not just physicians, it's all physicians, it's even CEOs, I'm even starting to hear stories of like billing people and all levels of people. I'm hearing workforce issues, just trying to attract them into the rural areas is really challenging. The other big thing is the 2030 requirements around seismic, and forgive me, I don't know where you're at on that with the hospital. Can you briefly just tell me, and that'll shape my conversation?
Well, we're under the 2030. Right now, we're in the process, and that was part of my report, but I'll say it real fast. In the process of purchasing the land over on the other side of administration over there for a new build where you have facility master plan.
So your current building is 2020 compliant?
It's 2020, we're good until 2030.
Okay, well that's good news. There's something this is something, so 2030 requirement is huge. It's a because of the ridiculous cost to build in the state of California, thanks to Oshkosh and other things, hospitals just cannot do it. It's just really difficult because of the cost. And even if cost wasn't the only concern, you've got a very busy economy, and there's a lot of contractors that won't come to the rural. You might go to build the hospital, and you might only get one bid for sheetrockers or whatever. And plus, there's new laws that require certain rules around union types of things that you might have to have union folks, and you might not even be able to get a union firm to come up here. So there's those kinds of issues. And what's important there is that CHA is very well aware of this issue, and there is a spot bill before the legislature right now. The language has not been written just yet. This is very much in the formative stages, but we are optimistic that we're going to get traction here. And in essence, what we're trying to do is there's been a lot of learning.
We're big supporters of that.
Well, do you know what I'm talking about? Because I don't know what you're
58 or
trying
whatever.
to. Yeah.
It's just that they're only gonna put the sizing standard on the emergency department, and it'll scale down.
Oh no, it's even better than that.
Oh, well.
It's even better than that. It's SB
We're happy with that.
758. It's sponsored by Fortantino. And what happened is CHA did a study, and they went out and they hired the Rand Corporation. You can't hire anyone better than that to do the study, and more respect that they were an independent body. And they looked at what hospitals need to meet these standards. And they estimated, after doing a lengthy study, the cost would be between $34 billion and $143 billion in the state of California. And that does not include financing. Well, those are huge numbers, and so those are the kind of numbers when people in Sacramento are saying that hospitals charge too much, that you can start to get attention to say, well, you're telling us we got to spend $100 billion, time out here. And so what this bill attempts to do is it says, like Steve was saying, for some hospitals, it's saying that in many hospitals, all that would have to meet the 2030 requirement is the emergency department, and it would only need to be functional for 3 days. But it even gets better. CHA intends to add to the bill that certain counties would be exempt, and Plymouth would be one of them. That could change your world big time. And if this bill passes, it could change big time. So I would encourage you to keep thinking about building and what you're going to do. And at the same time, I would encourage you to keep a close eye on what happens with SB 758. It's a huge priority at CHA. We'll be doing everything we can to move forward. There is significant opposition from unions and from consumer groups. And so that's going to have to be navigated. And you know, I'm sure there's going to have to be concessions made and things that we don't really want, but that's the political process. And so I don't want to get your hopes up too much, but that's out there, and we're optimistic that we can get some traction on it. So workforce is big.
Do you have a possible timeline for the decision?
Well, the way the bill works is it will either that's in motion right now. You know, the bills tend to pass in the fall, so it'll either go up for the governor to sign this fall, or in worst case scenario, I would say next fall. And you know, that it's a high priority at CHA, but like I said, there's significant opposition. So whether or not all of that can be navigated this year, or whether it will take another year to do it, time will tell. And one of the things that we look at is a lot of times it takes quite a while to educate the legislators, because there's a number of people that make a vote, and not all of them know a whole lot about the dynamics. And so if there's an assessment made that, hey, you know, we need to take more time here, and we need to have more, and we do. We go meet one-on-one with legislators on your behalf. And this is another thing I want to put out there is when we go, when people like me and Ryan go, they listen, they pay attention, we have an impact, we can change things, but they want to hear from you all. They don't want to, we're hired guns, and they know it. You are their constituents. You are the people that care about it. You are the people that matter to them. And so on this bill, and I've got a number of others I can talk about if you like, you may be getting a call saying, hey, can you go meet with your senator? Can you go meet with your congressman? There's going to be a call soon regarding Congressman Malfa. He stepped up big time for all hospitals in California. He signed on to 2 bipartisan letters that were significant for California. And we're going to try to organize a thank you event, and that's the kind of thing that we might, you might consider going to, because once again, I'll organize the event, and I'll be there, and I'll shake his hand, and he knows me and I know him, but that only matters so much. It's you all that matter to the legislators. So.
Well, we're going to have our estimated cost of the replacement facility this summer, and what we've said to your folks, the gentleman that's leading it at CHA, is that we'll...
It's changed. It was Dietmar. We hired a new person.
Okay.
She's awesome. Her name is Keone. She's
Okay.
awesome.
But we will show the difference of the cost right now and under SB 758, and push it through our forecast and show that it may not even be feasible to do if we have to pay $1,500 a square foot.
And that is awesome, and that's the kind of stuff that
20,000 square feet.
we'll see how things go and progress. Like I said, there may be a call where it may be like, hey, you and some board members go and meet and go tell that story. Like, hey, so anyway, I'm sorry.
Just a quick question about, you mentioned workforce issues, so I'm wondering if there's any legislative forward thinking about workforce. Maybe OSHPA is involved. I know OSHPA, I'm from a mental health background. I know OSHPA has done a lot of work pushing workforce capacity in the mental health arena, so I'm wondering about this.
Thank you. You said perfect segue. Ryan has some good news.
Sure. Yeah. So OSHPA has done a great job. Stephen M. Thompson is a great example of that program. I think they put up $105,000 for loan repayment. The Department of Healthcare Services, through the Proposition 56 tobacco tax, just received an appropriation. They had an appropriation last year of $220 million for loan repayment. That is assuming the governor signs the budget today.
We're optimistic you will.
It'll be another 120 added to it, and so they'll have $340 million in loan repayment that is targeted for underserved areas. There's a whole eligibility criteria, I'll leave it with Linda as well, that the department will be screening through. They have a contractor who's running the program, so OSHPA's hands aren't touching it. Otherwise, it may take a couple of years before placements actually happen. Former state person, I can say that. And so they're looking to get the ball rolling. They had over 1,100 applications this month for the program, and it basically pays up to $300,000. A big sales pitch, a big component of it, is that they're only reimbursing $60,000 per year, so it requires the physician to be located in the community for 5 years. And an eligibility requirement is that they must serve a bare minimum of 30% Medicaid Medicare. So it's directly tied to underserved areas who need physicians, specialists. I was telling T yesterday, if you're a child psychiatrist, you don't even need to worry about the application process. You're going to get selected, and they're going to find a spot for you. So those are the type of demands that the communities need, and the state has put a significant investment to start. You'll start seeing some docs now. That's statewide. There may be a few that come before this, but it should fund over 100 new doctors.
So the program itself places people rather than...
No, so it's part of the eligibility criteria that they send forward where they intend to work. It's not there's no sponsor needed by an employer or anything like that. It's up to the doctor, and it targets generally because the average debt for the practicing physician outside of the residency within the first 5 years is about $287,000. And so it specifically went above that, and it's really targeting those newer docs that can get them into the areas. And then research has shown as they were looking at the program and the structure, that if they're in there for 5 years in the community, they don't have a loan that they have to worry about. There is a sign that they'll be retained in the community. And so,
And is it for nurse practitioners and nursing staff as well? Or
it's
only?
mainly for physicians, doctors, and dentists. There's a dentist arm of it. There's no NPs or
So there's no qualification that the hospital has to do, it's doctor driven,
It's doctor driven, they apply for it.
The other big things, I would say, the stifling amount of regulation is something I hear about constantly. It's unbelievable. I hear about CDPH a lot. Fortunately, myself and people at CHA made it a big project last year to improve that, and there's been significant improvement with CDPH. Significant improvement. That's a whole other story, but that's gone well. OSHPD, we're working with them and working closely. Their CEO, Bob David, who runs OSHPD, he will come to your hospital. He will come talk to you. I'm here to tell you it's good and it's enlightening and it will help you some, but it's just a tough nut. We just left mayors where, they were telling us that they had an AC unit go out, and to replace it, if they would have just called somebody, it would be $15,000. They can't do that. They have to get OSHPD involved. To do the same AC unit to replace it, it's going to cost them $130,000. And that story, I have 1,000 stories like that. I have Coke machines that cost $200,000 to move 10 feet. I have so many stories on OSHPD that I won't get into. Another big story out there is the fires. The area I serve was hit by the North Bay fire, it was hit by the Carr fire, and it was hit by the fires in Paradise. And the effects of those fires is so long-term and so lingering and so devastating. And on hospitals, Enloe had 5 physicians recruited, coming to Enloe. The fires happened, and all 5 of them said, goodbye. Call me when this town is back together. They lost 5 physicians immediately. And at a time where not only did they lose those 5 physicians, but some of their existing physicians and existing staff left as well. And then the other thing too is their care mix shifted overnight. A lot of those patients that were in Paradise and Magalia now come to Enloe, and now Enloe is impacted with really high volumes and much more government payers. And that has compounded the workforce issue in the rural areas because Chico, there's no housing, Santa Rosa, there's no housing. And so, the interesting thing is, I could go off on this for days, but the interesting thing is it not only affected the people that immediately lost their house, but like in Enloe's case, for example, many of their hourly employees who were renting places got displaced because the people that lost their homes, many of them owned rentals and they needed a place to stay, so when the contract came up on the rental, they kicked the renters out so that they could go live in a home. So it's had a ripple effect on their workforce in every way, from hourly employee all the way through physicians. The other thing that's happened related to the fires is the PG&E power outages, and that's something that CHA and myself are working a ton on. We've got a good connection with PG&E. Having said that, it's very big, it's very new. I can tell you the outages in one of my hospitals was affected by one of the first outages, and I'm here to tell you it did not go well. Did not go well at all. The good news is that because of our really good connection with PG&E, a lot of the complaints that came up about that, they were very pointed, they were very specific, and I'm telling you there were life safety issues for sure. And we were able to get those to PG&E, and so far, we are seeing improvement. We are seeing that they are taking our input and that they are making improvements. For example, their mapping as to who would be affected in the outages was really rather ambiguous, and we told them that will not work. We need to know, is the hospital going down, is the clinic going down, is the pharmacy down the street going down? You can't just tell us that, this general area is going down. They heard us, they've worked with Oshkosh on GIS mapping, and that's improved. The other thing that's happened is, I know this is unbelievable, but in the first notifications about outages, law enforcement, fire, they were included, hospitals were not. Believe it or not. That has changed. They listened to us and said, we need to know first. And so that's gone well with PG&E. So those are the big things that I'm hearing. I don't know. There's some things going on in the legislature I don't know if you want to hear about. No? I don't know.
I think we're going to be running a little close on time here.
Okay, so there we go. That's fine.
We can reach you, though.
You can reach me anytime on any topic. Linda knows how to get out to me, and if I don't have the answer, then I can connect you to people at CHA that do, or I can connect you to other hospitals that may have a similar issue, and I can say, I can connect you to, maybe you're thinking about adding wound care. Well, I can connect you to a hospital that's been doing it for 3 years, and they can tell you how it's going. So, yeah.
Thank you very much. With that, we'll move on with the agenda. Has everyone had a chance to review the minutes?
I couldn't open them.
You what?
I couldn't open them.
Oh, yeah.
When I went to the security or the unsecured secure email that Pat sent out, they wouldn't open. It was the only attachment.
This is information.
So you didn't get to read
I
it?
didn't.
Hospital Council.
This
This is a
Yeah,
large update that I gave.
Rich, did you read it? Ken, you read that?
Takeaways.
Would you be
I'll
okay?
just abstain from it.
Could I have a motion to approve the minutes?
So moved.
No, I mean.
Second?
Second.
All in favor? You will abstain?
Abstain.
Dana?
Aye.
Rich?
Aye.
Ken?
Right.
And I vote aye. The medical staff report, Dr. Ware is not here, so we will just use this as a written report. And we will take the 3 sections individually. Has everybody had a chance to review the emergency department policy? Thanks again, guys.
Thank you.
Thank you.
The homeless patient policy.
Is this a new policy?
It's a new policy.
Required by the government?
Yeah, it's a brand new policy, and it was discussed at the medical staff meeting at the last meeting.
It's the SB 1152.
So I have a question on page 3, under medication. The very last bullet says the prescriber must ensure the label on a drug contains all the information required by law. Isn't that the district's responsibility? I don't know, Dr. Walls, if you want to...
I'm sorry, I don't know where you're at, but I will tell you,
I'm on page 3.
the hospital's not allowed to dispense medication. The physician has to do it.
Okay, so you're going to write on a label?
Yeah.
Everything required by law?
Yep.
Okay.
It's a little sticky.
And that's something that's been in effect, that's not new.
Yeah, that isn't new.
Okay.
Excuse me, I'm sorry.
And we mirrored PH's policy just to try and prevent shopping of hospitals because we have the best supplies.
There's a typo on page 5. The 3rd line down up at the top.
Oh, I see it.
I'm curious, Ken, what you think about the behavioral health section on page 4.
This is part of your new requirement, isn't it? Yeah. And so, well, my thought is there's really not much choice at this point. I mean, this is the requirement for the district, right?
And as Casey said, this is the policy that we are mirroring Plumas District and Eastern Plumas, so the Plumas County hospitals all have similar, if not the same.
But shouldn't we be reaching out to county behavioral health, not just contacting their physician if they say they have one? I mean, shouldn't that be part of this?
If they come in with with an issue, we would contact them immediately. I mean, if somebody comes in having a mental health crisis, they're on our policy through the ERs automatically contact them. On July 15th, remember? We have a meeting with Plumas County. They're setting up telehealth through PR is the plan. Stuff. 16th. So they might be able to change a little after that because we're hoping that there'll be 24/7 telehealth site.
They were moving in that direction last I heard.
Yeah, and I'll just jump right in. That's one of my CEO ones, but I'll jump in now because it's very, on the 15th, they're meeting with the other side of the Plumas County folks, Plumas County Behavioral Health. We will have a meeting between 9 and 10:30 if you want to come to it, with Tony Hobson, Behavioral Health. They're going to come and talk to us about how we will be implementing the Aligned Telepsych for Plumas County.
What day is that again?
It is, we're July 16th, from 9 to 10:30.
Here?
Here, in the conference room. So we've been moving forward with, on the ER side, doing the telehealth, psych telehealth out of the ER. And that's in addition to what we do over here on the clinic side.
It's all part of that opiate grant, where Dr. Wall said he didn't want to prescribe, naloxone and things until they had the mental health part of it. So in response to him, they were trying to come up with something else.
Any other discussion on that?
I just also wanted to bring up, so number 11, we talk about a written plan, but basically the only thing that's going to be on a written plan is a list of homeless shelters, so I'm not sure that we really have a plan that's going to be put together based on what I'm reading here.
Okay, so you want to?
The counties we're still working with PDH and Eastern Plumas because there's, we have to give them, July 1, we have to give them a written handout that has all of the resources. Chester does not have a lot, so we're still working with PDH and Eastern Plumas and the county to see what we can come up with to help these people. There's not, until we can all come together and make a plan, there's kind of a gap. But right now, anybody that comes in, we're not booting anybody, everybody's getting the assistance they need until they have a place to go.
Yeah, and I understand that. That's why I brought this up a few months ago, that we needed to get on top of this. I personally don't feel like this is complete. It's my opinion.
Well, and Jerry, I'm sorry you feel that way. We have been working with the county so that we can do a coordinated plan across the entire Plumas County. Casey and team has been working really hard at what can we do just on the Chester side of it, but we also wanted to include the Plumas County side of it. So that's why we have this plan to meet the requirements as we build it and move forward. It's not a static document, it'll be a moving document, so you'll see this back again. But I think the team did a phenomenal job of meeting with the county and working within our community here in Chester to get what we have.
Okay.
I move we accept the policy with the understanding that it is in process.
Well, okay, there's a motion. I would just comment that all policies are subject to revision. Is there a second?
I accept your.
Is there a second to that motion? Vote?
No.
Vote no. Dana?
Yes.
Rich?
Aye.
Ken?
Aye.
I vote aye.
I'm sorry, who was the second?
Ken seconded it. Okay, the appointment for Igor, I'm not going to try to pronounce these names, consulting telemedicine, and this is an initial appointment. What is his specialty? Radiology,
Yes.
yeah. Are both of them radiology?
Yes.
Yeah. So, can I have a motion to approve?
So moved.
I'll second.
Moved and seconded. Vote. Ken?
Aye.
Rich?
Aye.
Dana?
Aye.
Jerry?
Aye.
And I vote aye. And then Jay Donahoe, can I have a motion on him?
So moved.
Second?
Second.
In favor? Jerry?
Aye.
Dana?
Aye.
Rich?
Aye.
Ken?
Aye.
And I vote aye. That brings us to the financial report. Steve?
So, the Finance Committee met yesterday, and we talked about numerous things, of course. But one of the things we talked about was trying to shorten up the financial presentation, and based upon my ability to get the information to you no later than like we did this week, where it's a Monday morning, on a Thursday meeting, that I think the Finance Committee felt that there was adequate time for the information to be reviewed, and then to just do a very, very brief highlighting of the elements of the month, and then put it to you guys for questions. So, with that said, May was one of our crazy months up here where it does rain money. So, for the month, we had a huge profit, just over $4 million on compared to a budget of under $4 million. It was due to a couple of things that we received 3 supplemental payments during the month. Our fiscal 17-18, and the key thing there is 17-18. We're in 18-19, so they're still a year behind on the rate range payment to us. We have seen the documents for the rate range for 18-19, which will be paid in 19-20. The rate range was just under 2.5 million. The hospital quality assurance fee, again, another 17-18 payment, $805,000, and then continuing payment under the Pine Grant, $675,000. So all those together, we're just under $4 million. We received just under $219,000 from the KBK Foundation, and we'll show in the capital budget, and as we've discussed, we use it to do a major upgrade on the equipment in our lab. It's going to be a really amazing thing when we're done. And then we also received one of our semi-annual county tax checks. We still struggle a little bit with expenses. They did come down a little bit, certainly the salaries did, and we still continue with contract labor, so I was half serious, half joking about the guy showing up with a car full of nurses. So that's really where our struggle is. We have hired a radiology tech, which was under full contract right now. We had a full FTE, if you will, under our contract arrangement, and that basically doubles their cost. The big thing is that now, at the end of May, our days of cash on hand are just under 114 days, and this will continue to grow in the month of June as we receive additional payments. As it says there, that we will and have received about $2.3 million in additional payments in June. Just a couple notes under the key financial ratios. I did not update the days on cash on hand. We moved the KBK money into designated. When we cite our days of cash on hand, that's what we call unrestricted, so it's undesignated, whether it's by the board or some other source. And we consider the KBK money designated by the donor. I wouldn't put it under unrestricted cash. So under the key financial ratios, that should be 113.6, and this is for Dana. Our debt service coverage is now 2,283%. So I think we can.
Were you expecting me to pay some?
No, you always wondered why it was negative. All year long it was negative, and so now it's just out of line. So, yes, we are profitable, and yes, we have very little debt. Did anyone have any questions or comments about the financials?
I just did on the pro fees medical
Uh-huh.
section. I think maybe there's a calculation
I hope not.
issue, potentially. Because if you look at the top line for emergency room physician fees, it shows us being over budget by 3.7, and both lines below say over, so, I mean under, so,
Definitely a problem.
yeah.
Thank you.
I'm sorry to interrupt. Does anybody mind if I turn the ice box down?
That would be fine with me. I'd be happy.
Yeah, you have to do both sides.
When you want it set up, sure.
Where you got it set, Dan?
What temperature are you putting it on?
I put it on 75. Where should I put it?
I have to match it over here.
What?
It's a dual thing, I'll put it up to 75.
That's your genius.
So if you're interested in the real numbers for the emergency room physicians that get us to the negative balance, we did use some locum physicians, as you can see there, $17,000 anytime we use locum physicians in the emergency room. It's going to be it's going to be at a negative budget variance. We pay them about $150 or so an hour, and our budget's $135.
Thank you.
Okay.
Any other questions for Steve? Then moving on with the budget.
Do we have to accept it?
Accept it.
We have to vote to accept
Oh, the financial report.
it.
Accept.
Can I have a motion to accept the financial report?
So moved.
Second? All in favor? Gary?
Aye.
Dana?
Aye.
Rich?
Aye.
Ken?
Aye.
And I vote aye. Okay, moving on with the budget.
Okay, under my tab D, I have the capital budget as well. So the first page of your tab D should be fiscal year 2019-20. Jacob, can you go to that other one, please? Should be fiscal year 2019-20 budget presentation. And it looks like everyone else is grayscale, so that's good. Okay, so let's go to slide 3, Jacob. So this was the budget that was presented to you all last month. It kind of kept us where we're at this year from an operational standpoint, and was also prepared based upon Dr. Salehi leaving. And so we were down a physician. We did some juggling of trying to see if we could up the utilization of the nurse practitioners and keep Dr. Walls and Dr. Ware where they're at, and see if we could absorb Dr. Salehi's practice. And so we did, but you guys said we need to do better than this. Tell us what we can do. And in the presentation, we had some things that we referred to as revenue enhancement. And so what we did is we went back and we reflected on that. Jacob, if you go to slide 8, which would be page 4 in everyone's books. And so we went back and we redid this considering the items that were in the revenue enhancement and the things that we looked at. Jacob, if you go to slide 5, or slide 9, sorry. That's what you tell them. And so we looked at some revenue enhancement. And the things we looked at is, we looked at clinic visits, and this has been a fun budget. First time we do a pass-through, a doctor leaves. The second version of it, a doctor shows that we get to recruit a doctor. So we were kind of all over the place with pushing the numbers around. But the good news is that this is, this additional provider here is one that we have an agreement with, and so it's not one that we have to recruit. So we increased the clinic visits with an additional provider. We increased at some projection of lab and radiology, our diagnostic utilization, because we're going to have additional patients coming through the clinic. When we originally did the census, it was at 14.98, which is one shy of full. We're running full now, and these guys are having a really fairly easy time finding new placements. So I don't think that we're going to have open beds for much time. And so we went for a budgeted census of 15.5. So some consideration of beds being open for a very, very short period of time and then being full again. The other big thing is that we had lost our occupational therapist. Here's another one where originally when I did this slide that we were in negotiations. By the time I finished the slide, as you'll see, we actually were making offers to these two providers. They're just going to support our swing bed program. So what we did is we brought our swing bed census back to what it ran at this year of 1.07. And then there's, of course, a corresponding increase in ancillary revenue. It's not just the bed charge that we have the ancillary, whether it's pharmacy or occupational therapy, respiratory therapy, whatever it might be. And everything else stayed the same, no rate changes. We had an increase in our contractual adjustments from a dollar perspective because our revenue went up. And that our adjustment to revenue percent because of the swing bed pays a little better as the hospital as a whole, that it came down from 48.49 to 47.98. Jacob, let's go to number 10, the next one. Okay, so associated with this, we had some increase, and one of the things I did that I know provided some confusion was trying to compare year to year. So all I did with this one is I just compared what we previously provided to you back in May versus what now. So just the change of the things that happened, the additional provider, the occupational therapy. There's really no cost associated with a little higher long-term care census. It doesn't change our staffing, some utilization of supplies, a little bit in the meals and all that, but overall it's certainly not going to impact our staffing. Actually brought down the hourly wage, it was down a little bit. We did add 2.8 FTEs. It was from the clinic, essentially the support staff for the new physician. We did some cleanup, a little tiny bit of cleanup on the budget as a whole, and so we had a small adjustment to surgery, small addition to surgery, and then a small decrease to lab. Have an increase in our professional fees, and this is almost solely due to the addition of the new physician. And when we did the projection for May, what we said is we were going to bring the nurse practitioners in, we're going to set a baseline for them, we'll talk about it in the contracting part of the meeting, and then we will build an incentive if they can see more patients, because we thought for sure they're going to see more patients, there's going to be a demand, there's going to be this shortfall from losing a provider, a provider that had a patient base and had a nice volume. So we built incentives in for them to see above the baseline. So when we bring in this new physician, we don't think that the nurse practitioners will necessarily go into this incentive, that will be absorbed into the physician's practice, and that we won't have to pay the incentive. So we brought their estimated pay down a little bit, and then the cost of it's an occupational therapist and an occupational therapy aide. So next one, Jacob. Okay, so where this leaves us is that we're now projecting that after our bottom line, after we've had the supplemental payments, less the intergovernmental transfers, that we're now projecting net income of just over $2 million. Looking at this from a cash flow standpoint, we would add back depreciation, which is a non-cash expense, and we have principal payments on long-term debt of just under $23,000. that would leave net income what we would call available for capital purchases. So let's go to slide 12. And I think we've kind of talked about this. This was the actual slide. I have to work on my organization here a little bit, but this is the slide we talked about, that these are the things that we had identified about possible revenue enhancements. So we kind of discussed those, talking with the numbers. So let's just go through these real quick. 13, Jacob. Lucky 13. Swing bed. So again, we lost the occupational therapist. We made offers to the OT and OTA. What we'd like to do is we'd like to have them here, working here, getting the way that they're going to administer the program, if you will, the way they're going to do their business in place by the time that Dr. Cooper starts, and that would be when we would target to sometime thereafter to start taking on the swing bed volume, which we're projecting to go from the 0.3 in the last budget to, excuse me, to just over 1. This will result in an increase in gross swing bed revenue of just over $1 million. And this includes the ancillary service revenue. The cost of the OT and the OTA for 50 weeks. So from July 15th, and you know, everyone says, "Wow, gee, $57,000 to make $1 million, huh?" And what it shows is it shows the idea of the underutilization of the acute side. Is that we have this minimum staffing of 2 nurses or 2 nursing staff per the state regulations, and we can handle up to 3 patients on the floor with that. Our acute census runs, you know, barely at 1 itself, and so we can take on this additional swing bed volume and without any additional labor cost, and that's why it's such a crucial thing for us to take advantage of, or to utilize, or whatever the right word is for us to do, I guess. And like I said, no change in the inpatient average day census. So next one, Jacob. This is the clinic providers. So we had talked about bringing in a physician to work with Dr. Walls and absorb patients from the Slade Swartz panels, and what the missing piece there is. Patients that we're looking for physician providers, because we think that we can absorb a lot into the nurse practitioner or nurse practitioner's practice. How things work with Dr. Walls and Dr. Cooper and all that, that's just something that will just have to play itself out once Dr. Cooper gets here, and we'll see how that works. As I mentioned, 3 full-time employees, a scribe. We're going to try this new thing with Dr. Cooper, where a scribe follows along and takes all the notes, and see if this allows the doctor to, 1, spend more direct patient care time instead of clicking and typing, and also whether or not they can see more patients.
See, just a quick off-topic question about the scribes. Do people have the option of saying, "No, I don't want to use a scribe in the room with me"? Do we know that?
For the patient?
Yeah,
Yes.
they do.
The patient has that right.
Okay.
And then the medical assistant and the receptionist, with all this, it's additional annual cost of $132,000 for salaries and benefits, increase in clinic revenue, increase in clinic visits from 11,003 to 12,437, excluding telemedicine. This is still below the volume we saw back in 2016, the last time we had a full stable, if you will, of providers. Okay, and then again, we talked about the increase in outpatient diagnostic lab and radiology. This is all due, kind of a dual thing, is that with the greater clinic volume, this is where the referrals go, is into lab and radiology, and that we're going to try and formally promote Saturday hours. We have the techs here right now, we have registration staff right here now, we need to make it the public aware that they can come here on Saturdays, just like any other day of the week, and have lab and radiology. Okay, so the last thing was, we talked about other revenue enhancement ideas, contract with physical therapists to support swing bed program and increased outpatient utilization. In order to do this, we're basically down to the option of, we have two options at this point, I guess. One is to put a new modular unit where the existing physical therapy sits, because we have a license for that address. It would have to be 2020 compliant, or it would have to meet certain, it wouldn't be just plopping down a building, it would have to meet certain strict guidelines. We have no idea what that cost looks like. The other idea is to renovate the remaining part of the second floor here, and that's going to be a big number too. We're expecting a number from the architects what that might look like. It says here the capital investment with that will be significant. We haven't considered, we don't have a number, we haven't considered that in our capital budget. That's going to have to be something that we're going to have to see that the numbers even pan out. The expansion of outpatient services such as wound care and infusion therapy, that's kind of a, Dr. Walls can correct me on this, that's kind of a physician-driven thing, I guess, if we can see that the providers' patients need this type of surgery, and how we coordinate that with the hospital staff to provide it. We're doing it to some level. It's not a bad business, and it's something that we would like to see we could do instead of sending it out, but I think that'll be a coordination between nursing and the providers. But what kind of came out of this was when we met with Kim Pitts from the surgery department, that she had an idea about there's a service called GERD, which is basically, most people know it as acid reflux type disease, whatever the right way to call it is, acid reflux symptoms. And we met with Dr. Jensen, and we met with a vendor that provides the support for this, the software and equipment and all that. And apparently someone's doing it down at Enloe and then Sacramento. Nobody's doing it in our general area. There's no competition for this. And this is something that we could do. Dr. Jensen is capable of doing this procedure with I say, what do I call it, moderate capital investment. It's about $130,000. We've run preliminary numbers that it would be profitable, and it would probably take us a couple years to return our capital investment based upon very low estimates. Dr. Jensen says we could do 2 to 4 patients a month. So we'll run an ROI on that, but we'll take that a little farther, and I think everyone's behind that, and that looks like something we really can do.
Is that something, sorry, is that something that can come out of our market research that we haven't seen for that one?
I'm certainly going to ask them if they've looked at that, that CPT code or that diagnosis code.
I think it's important for us to know.
It came out more so from a physician-driven side of it, when we asked the physicians what services would you like to see that we could do that could be financially profitable for us. Dr. Jensen stepped up and said, hey, I know that I'm passing these off, we can get these done here, you just need some equipment, let's talk about it. So not so much from the market feasibility study that we were doing, but more asking the docs, what is it that they want to see? What can we do here? So it's more of that inside the organization.
So Dr. Walls, are the other physicians referring patients for this procedure?
Well, we refer to GI, and then they do the referral for the pH monitoring and things like that. So I don't really refer directly to have that test done. Dr. Jensen does all of our scopes, so he would be ordering those tests.
Okay. Did he indicate how many he refers?
Well, that's what he was telling us, and what Steve just said was that the 2 to 4, we could probably do 2 to 4 of those patients a month.
So he's referring every month between 2 and 4 patients out
that we could be doing here. And It's a motility study, so you're not just talking about one procedure, it's actually 3 bundled procedures, so it's 3 separate times.
Maybe you can talk about that a little more.
So you have to have the first visit where you have the clinic visit, and then you get an EGD done, which is an outpatient surgical, so you get that done. Then you get the diagnosis from that EGD, which is another clinic visit, and then you have to go back for a TIF procedure. And I don't know what TIF means, but it's a TIF procedure with another EGD. So that's another surgical procedure you have to do. And then another clinic visit, and then you go back again for another you either get a motility study or you get a implant. So it's a bundle. I mean, it's not just one procedure, it's a bundle of procedures for this whole GERD motility study.
And we have between 2 and 4 people every month that have to have that.
That's what Dr. Jensen
Well,
says.
he's also including Quincy because he
Oh,
would be
got it.
bringing his Quincy
Got it.
patients.
That makes
Susanville
sense.
as
That
well,
makes sense. Thank you.
potentially.
Okay.
Yeah.
So we become the regional center for this.
There you go.
Cool, I like it.
So we'll bring you back some number. We're not asking for anything from you all today. The other thing is that the contribution to our bottom line would be minimal. I mean, everything counts, but and it would pretty much get eaten up in trying to pay back for the capital investment, at least initially. So it's not a game changer to our budget, but it's certainly something we have to explore.
Well, and it would be a service to providing to our community that are currently going out.
This all flows with the conversations we've had about having services, and hopefully people who've fled will return.
And that was one of the questions I had posed to the physicians. What are some of the services we can do here? Give me some ideas.
So Jacob, if you go back to slide 8. Please. Of this file.
I think he has to travel.
Oh, you already moved on? Okay, so that's what we're proposing to you all. It's also in a different form at the end of the presentation in your board packet, so page 9 in detail. It represents a 12.99% loss, operating loss, which is still above where we want to be, but it's certainly a step in the right direction.
It is closer than the last time we reviewed it.
Not to derail the thoughts now, and the way that we built this model with some utilization out of Dr. Wall's office and some utilization out of Dr. Ware's office. And so we don't know at this point what that will look like for Dr. Ware this time, but it's the model we have to go with. This is the model that makes our finances work, to have some combination of 5 providers in here.
And I think, it looks like we're trying to move in the right direction. We're trying to provide more services. We need to bring in more providers for services rather than trying to rely only on our existing providers as well.
Well, I understand that, and I have a report for you on that.
Yeah, and we are dependent on 5.7 million in supplemental payments, so we have a net bottom line of positive 2 million, which we still need to tighten that up quite a bit as well. But overall, I think that this is I appreciate this version of the budget.
Is there any further discussion on the budget? Ken, you have anything to add?
No?
Rich? Dana? Jerry?
I'm good.
So,
I can move we approve the budget as presented.
is there a second to that?
I'll second.
All in favor, Ken?
Right?
Gary?
Aye.
Dana?
Aye.
Rich?
Aye.
And I vote aye. Budget is unanimously approved.
Wow.
Thank you.
Thank you, Steve, for all that work.
Good feedback from everyone, and, yeah,
Well prepared, Steve, thank you.
we'll do it on the first time next time. Okay,
You will.
so, yeah. So when the finance committee met yesterday, something came out that was really good and real positive, is that the way we're going to approach our capital budget for Seneca is that we're going to bring forward, staff is going to bring forward, whether you want to call it a proposed capital budget, a wish list, whatever it is, and that we're going to ask the board to designate funds in the amount that's reflected on that capital budget, unless you guys want to pull something out of there and say, no, we don't want to do that at all under any circumstances. But get to a number that this is the amount. We'll move the funds into designated, and then as we want to purchase assets and use those designated funds, then we will have to come to you for approval on those purchases. As always, regardless, anything over $25,000 has to come to you guys as well. Okay, so Jacob, slide 3, or the next slide. Okay, so just to kind of give you guys an idea, so we can get a perspective or understanding about the money. We talked about the cash flow from the budget you all just approved. So what we're projecting at the end of this fiscal year, which is essentially Sunday, so I think we have a pretty good idea where our money's at right now, that we project we're going to have total unrestricted cash and cash equivalents of $7,237,600. That's going to reflect or represent 151 days of unrestricted days of cash on hand. So that's fantastic. No debate there. What we have right now on our balance sheet is we have $538,843 in board designated cash for capital additions. And this is money that we just put a $500,000 in there last year, and we've spent some of it, and then we added $218,665 from the KBK grant. So right now we have that amount sitting on there designated for capital additions. In addition, we have that second board designated account, which I have given up, and I'm saying that that is board designated cash for operating or other reserves. So, and that represents 13 days of cash on hand. So right now, starting the fiscal year, we're sitting on 151 days of unrestricted cash. We've got $538,000, $539,000 in board designated funds for capital additions, and we've got $612,000 in board designated reserves. Okay, so Jacob, number 4. And this again is a reiteration. With all that said, the last slide was 6/30/19. This is what we're projecting going forward. If we hit our budget, this is what we'll do. We'll add $2.4 million of funds to our balance sheet. So next one, Jacob. Keep going. Okay. So what we've done is we've identified a potential capital budget. I don't know if you guys want to open up your rings and pull out. It would be page 7, the 7th page of your packet. And this is our wish list. This is our proposed capital budget for the year. And as it says there, the total amount is $1,645,837. It's broken up into 4 categories. One is stuff that you all approved that we haven't spent from this fiscal year. The next is plant and infrastructure identified needs. This is from working with Linda McCurdy, other things that we've identified that need to be done. These are pretty crucial. These are really not open to a lot of debate. $555,000. Then we have medical and non-medical equipment. in the amount of $723,000. And then this last one is what we call service line expansion return on investment amount. And right now that's just the estimated capital cost of the GERD surgery. So this just goes, this just takes into a presentation format what's on the summary page. You can see the things. You guys had approved a replication server this year. We haven't bought it yet. And then all the stuff related to the facilities master plan, market study, and the acquisition of the Collins land. So next one, Jacob. Okay. The lab, you know, what is it? You put brand new furniture in a house with worn carpet. So in addition to replacing the equipment in the lab, we're going to be replacing their cabinets and workstation and the lab flooring. This was something I think that strengthened our grant application with KBK because we reflected this as an in-kind contribution by Seneca, and the fact that we're telling them that we're redoing this whole thing. This is going to be a redo of the lab, and we're doing it in partnership with you guys, and they must have liked that because they gave us the whole amount. So the next two items, and you'll see when you look at the summary page, the hospital roof refurbishment and the hospital HVAC chiller. I mean, story about the $15,000 air conditioner that cost $150,000. So this needs to go out to bid. These are the numbers that we put it out previously, and these are the numbers that were bounced around by contractors, but these are going to have to go to bid. And we'll have to make a decision about what we want to do with the roof. Can we just, you know, fix some of the things that need to be fixed and put the resurfacing on it? And then as far as the HVAC and the chiller, what we'll be able to do just to push enough air in there so that it can make it climate appropriate for both patients and staff. So these numbers could change. Long-term care refurbishment, we started this when the previous DON was there, and we want to bring this back, and those numbers are pretty solid. As is the CT ramp to the hospital. If you guys have seen that, then I don't think there'll be any argument about that expenditure. And we do have some initial quote on that. Equipment, the lab equipment, this is all coming from KDK. The transport van, we bought the initial van. We had some money left over from the $80,000 Collins grant, so we chose to get a second, smaller van. And we think that the number is going to come right in here that we're going to have to pay out of our funds after we've spent the Collins funds. X-ray table, our current table does not.
Sorry, can we back up for a second? Why, we're saying we need two vans?
That was what the staff recommendation was.
One is a smaller van for doing little runs around. The other is the bigger for where they're going to take trips all the way down to Chico. They can take 3 or 4 people at a time rather than 1 or 2. But the smaller one is for small runs with 1 or 2 people just here locally, that type of thing, or if they only can take 1 or 2. The other part of it is, which, correct me if I'm wrong, but there's cases where we give people rides home from the hospital. There's staff members that do that with their own vehicles, so we kind of don't like that.
Well, no, I understand that. That's why I thought that's why we were purchasing the one van. Why do we need two?
Because one is a big van.
Sure.
They can haul 8 to 10 totes. The other is about 3 to 4, maybe 5 folks. So it's for 2 different kind of functions.
So the other issue is when we have some larger functions, and actually you can help me with this, and we take our residents, one that I vividly remember was when we took them fishing that year, and we had to make 4 different trips to get them there. So this way we have the 2 separate vans. That's one example of why we chose the 2 vans. The other example is because instead of putting somebody that comes into our acute building and we have to drive them home, instead of using the big van, we're using a smaller van so that any of the employees who are on the insurance can drive that smaller van to take that patient home versus not everybody will have the ability to drive the bigger vans. They're not comfortable driving it, and so this way we've got both.
Linda, I guess maybe you said this, maybe I just missed it.
Yeah, no,
but
that's-
It sounds like the benefit of 2 vans might be that one is out of town,
Exactly.
and you
Thank you.
have schedule conflicts.
Exactly.
Was it a condition of the grant that it be used for transport or?
When I wrote the yes, I'm sorry, yes. When I wrote the grant, it was for transporting both our skilled residents and also if we had acute patients or ER patients that needed to have transport home. That was part of that grant. Also part of that grant was a possibility of if we had enough money, we could purchase 2.
How much is the cost of the second one in total?
I'm sorry.
Jim has that, the cost of the
cost of the
second van.
second van?
27,000. And we had about 15 to 20 left over from the grant, so the rest of it was absorbed. We put in 25, but it's probably less than that, as far as what our costs are going to be.
Okay. It sounds like you just said that we don't have to pay about 3, but that says 25, that's why I'm questioning it.
No, we got the grant for 80, for 85. 80, we bought one van for 67, that left us was 13. The van is 27,000, so you got about 10 to 15,000 left over that we'll have to pay. But we're anticipating taxes, licenses, maybe if we added a few things,
Okay.
the bottom line is maybe 25. Okay.
The final invoice. Okay. The x-ray table, our current x-ray table does not move up and down. So that's both a
Patient safety.
comfort and safety issue. So the ER has requested a gurney that has a scale. Everyone's favorite subject, the emergency department EHR is in there as directed. And what we want to do is we want to try and replace all of our hospital beds. Ultimately.
All 2 of them?
Yeah, ultimately. It's something we can do. We just got a deal from Hill-Rom where they came in and they had 2 top-of-the-line beds for $7,000 each that are normally a $25,000, even $30,000 bed. And we just told when the guy came here, sales guy was with us, he said, hey, just call us if you get these deals again. And we will absolutely. I mean, if we can throw 4 in there for 40, we're going to get 4. So, and I didn't mention, but with the long-term care refurbishment, we're going to replace all the mattresses and get a couple air mattresses, if I say that right. Not like the ones you put
The
out for
pressure
guests.
mattresses, so that the mattress rotates itself, so it'll avoid pressure sores.
Yeah, very important to have. And then the last thing is the GERD surgical. I mentioned in my narrative that this was brought forward by Kim Pitts, our surgery department manager, and Dr. Jensen to capture this unmet market need. I probably could have listed a few more counties that don't do it, but just most significantly, no one in Plumas or Lassen County did it. So, and then we haven't looked at the TIF part of it yet. We've looked at the first 2 pieces of it. It's a separate, who knows why, it's a separate company that does TIF versus the first 2 pieces. So we've looked at those, and that's what's in the 130, and we'll be meeting with the TIF guy next week. And as I mentioned here, it will require an ROI analysis for board approval. So where this leads us is that we have this potential capital budget of $1,645,837. We have $538,843 already in board designated. What we're asking the board is to move $1,106,993 into board designated for capital additions, so that we will have the full amount that's currently on the wish list, proposed capital budget, funded, but then as we say here, any item to be paid from the designated funds will require board approval, and any capital item greater than $20,000, as always, will require board approval. That's where we're at.
Are you asking for this now?
I'm asking for you guys
To approve this now?
to approve to move the $1,000,001 into a designated status.
Does the treasurer have any comment?
I agree with it, with the recommendation.
Any comment from other board members?
Just a question. Are any of these items things that we will be then having to duplicate with the new bill? I mean, obviously we have to replace the roof, right? But I'm just asking more, I think, about the equipment.
I think we wrote in the grant and said to KDK that we're going to take the lab equipment with us. It's all contingent upon how long it takes us to build that hospital. The lifespan of lab equipment is 5 years-ish. The way that we take care of it and utilize it, it has a longer lifespan. The X-ray table, I'd say no. I'd say that we want to build a new X-ray unit. We said we'd take the beds with us, or we've said we would take the beds with us.
And I'll take the vans with us.
That's how we're getting over there.
Should we move forward, we'll most certainly take the GERD surgical equipment. IT server, again, that's our anticipated occupancy of the new facility is right about the end of their lifespan.
Okay, thank you.
The emergency department EHR is portable.
Hopefully.
So, you can, whether it's relevant, we'll find out, whatever form it comes in. So a lot of this is, it's a good question, is that a lot of this is an investment in today.
I really appreciate this capital budget.
Well, we have one more piece, Dana, that we'll bring to you. We have done the end of life thing, but it's amazing because the end of life of our capital assets that we're not replacing, and the end of the useful life, the departments will say it's at its end of life, but it's still useful. We can still use it. Our radiology machine is well beyond its useful life, but it still is very functional and would be quite costly to replace.
Till the day it isn't.
What's that?
Till the day it isn't.
Can we have a motion then to?
Sure. I move that we approve the capital budget for 2020 as presented.
What we want is a motion to move the funds.
Move the funds to designated.
Okay.
That work?
So moved.
Okay. Second?
I'll second.
All in favor? Jerry?
I'm sorry, let me back up. What is the motion?
The motion is to move the one.
I should withdraw the motion and do it right. I move that we approve $1,106,993 to designated funds.
Board restricted funds.
But
Yeah. I'll second.
All in favor? Ken?
Aye.
Jerry?
Aye.
Dana?
aye.
Rich? And I vote aye. Okay. The last page is pretty self-explanatory on your report. Here it is.
Oh, right.
I don't think we need to go
Okay.
into a discussion on that.
Okay.
All right. Can we move along then with the contract revisions?
Yes.
Don't shoot me, but what about upstairs remodel? We do that.
That's what I just mentioned. That's
We
self-explanatory.
just need
I don't think we need to get into a discussion on that. It's just a small overrun.
I was still recovering from that motion.
Okay.
So on the primary care physician agreement, what we did was look at the compensation piece, and let me get to that page. I tabbed it. So what we did on the compensation piece is previously Board had given me authority for the, it's going to be page 6 of that first set. The Board had given me authority for during the full amount of time. It seemed more realistic to go by the RVU base. That was one of the things that we were looking at with Dr. Saleh in her contract. She wanted to move more towards RVUs. So when we looked at that annual salary and what the updated RVU amount should be, that moved it to the $52 per RVU from what we previously had.
That the family practice, full-time family practice internal medicine should be doing about 5,000 RVUs. So we just did simple math and we said 5,000, that's our target for a full-time provider. And so if we're paying $260,000, it converts to $52 an RVU. With Dr. Jensen, we were paying him RVUs and we were paying him, we continued his on-call arrangement. And that has since ended, and so we needed to terminate that deal and then get him under straight RVUs, but we were paying him well below the $52. So we ran it through and put the $52 in there at his historical RVUs for the last couple of years, and it comes out very close to what he was paid in total compensation. So he was comfortable with having a straight RVU contract at that rate. And then all of the primary care physicians will have the same arrangement.
So that's two contracts kind of merged into
Yeah.
one. So you talked about the primary care physician agreement, and then you also talked about the specialty Dr. Jensen's agreement, which is further down in the agenda there somewhere. So if we can start back with that primary care physicians agreement, and you're going to see further on in there, the contract that we signed Dr. Cooper under is the agreed upon contract that the board had given me authority to sign. So he signed on that contract. But what we're looking at now is if we can move those RVUs up to 52 per RVU, which equates, as Steve told you, to that 260, it just gives us a different way of being able to recruit some of these doctors for an RVU base. They feel that if it's at 52 per RVU, they might have the ability to make more money than the 260 annual. And that's just, as Steve said, there's a ceiling there. Whereas if we go RVU based, then they have that ability. So I needed the board to give the authority to add this 52 per RVU.
And so on, you still have the other option.
Yes. Because on the other contract, it was not at $52 per hour. It was what, 47, 40? So yeah, it was very low. So my request is that you give me the authority to do the contract at this, on page 6 of 16 is the change of 52 per RVU or equal to or less of 5,000 RVUs per calendar year.
So how many RVUs are we seeing today?
It's all over the place.
And Linda, when you brought this contract to us in September and we approved it, you told us that we needed the $260,000 as a flat rate because that's what the recruitment company said, and that's what you needed to recruit and retain.
And that's what I
And you
needed
did
back.
and you did recruit somebody with it, now you're wanting to change it.
I want to change, I want to add, I don't want to change, I want to add, so I guess the verbiage is wrong.
I don't
Please
see-
let me finish. So when I'm trying to recruit physicians now, the other question is this an annual salary or can we go by an RVU rate? So I need that ability to be able to recruit, to bring in two. Things change, you heard T say, healthcare changes every day. Trying to get these physicians in here, I need to be as flexible as I can to recruit these physicians. So that's why we're coming to you to ask for, give me the ability to offer this 52 per RVU rate with the equal to less than 5,000 RVUs a year. That's
Or a
what I'm
salary
asking.
contract.
Or a salary contract, that's what I'm asking.
I mean, it really goes back to when we had this conversation before multiple times, that we really should be offering a contract for a new position where we guarantee a certain amount for the first year so they can get their practice established and then convert them to an RVU basis. And I've brought this up multiple times and for whatever reason, we haven't really looked at it seriously.
We have looked at it seriously, and when we've talked to the recruiting company, or the different recruiters, These are the models that these positions that they're recruiting to come into are looking at. These are the models. Now, we can add on to another contract, which your suggestion is a 260 base income guaranteed for 2 years. That's still on the table, that hasn't been off the table.
Well, I haven't seen it on the table. That's my point.
We
And I
had
mean,
approved-
if I'm in a position, I'm not gonna sign a contract that says $52 per RVU when I have no idea how many RVUs I can actually realistically attain.
But you don't have to. The option.
Well, then why would she need this contract then?
For positions that are less than full-time. So what we really need this contract for, Dr. Walls is already on an RVU, straight RVU basis. Dr. Ware went on a salary basis and failed to meet the production targets. And so now we need to move her to a straight RVU-based contract, just as Dr. Walls is.
Okay, well,
And
that's a
you
different
have already-
conversation than recruiting.
Well, and you have already given me the authority to give guaranteed income. That standard income guarantee for a recruited position is $260 per year for a total of 2 years. This will be documented using the recruitment assistant even. You've already given me that, and that's why I'm a little confused, because it's already on the table. You've already given me that authority. I can use that authority to recruit, but not all the positions want that. They want to go to an RVU base. So what I'm asking is, give me the flexibility to present all these different options to get whatever positions out there to come here.
I think what you're actually asking is for us to increase the RVUs so that our positions that are already on that basis are paid at the same rate, which is a fair question to ask. I don't think that saying that's part of the recruitment strategy is actually an accurate statement.
Yes, it is, because not all of the positions I'm trying to recruit want a full-time position. I've got 2 physicians that are talking to me from Eastern Clinics who want part-time, but they don't want the 260 income guarantee. So it's a whole big package, it's a whole picture. I'm looking at the whole picture of recruiting new physicians, physicians that are existing and have practices. I'm trying to bring that big picture to get a position here. This is what you tasked me with, is to bring in physicians. So I need to have that flexibility in all these different areas to recruit, to get them here, to entice them here.
What would you like the motion to say?
I would like the motion to say that we can, part of this authority for me to bring in physicians would be moving the RVUs to 52 per RVU. $52.
I so moved.
Is there a second?
Second.
I'm going to abstain from voting. Ken?
I'm gonna go aye.
Rich?
Aye.
Dana?
Aye.
Jerry? Okay. Moving on.
Okay, under tab F also, you will,
Is that for the specialty as well?
they have to go, that's a whole different one. So under the allied health, practitioner, we've not contracted with the allied health before, they've always been employed. Currently, Stephen Hayden, would like to be an independent contractor with us, so we took the contract that you're used to seeing, I sent it off to, legal. Legal is still giving me some, just the verbiage in it. What I'm asking for is, Steve and Jim got together and we looked at what the base compensation would be for a allied health practitioner that is, an independent contractor. So they had come up with that base compensation of $176,800 per year to include 47 weeks worked and 5 weeks of personal time in CME. You'll see that on page 6 of 18. And all what we did is take what we would have done for an employed mid-level and moved it over to a contract.
So the same salary.
Same total cost. So if someone came in on an employee basis, they'd be, whatever, 30,000 below that, and then we'd add health insurance and a little bit of CME, we pay their FICA, Medicare, workers' comp, malpractice. So it works out about the same. This contract is written specifically for Steve Hayden because of his years of experience. Jim and I were looking at this, the conversion on this, this person would fall in step G on our scale. So this is a highly experienced person, and we would have to say if we're serious about moving forward with the student, she could fall in a different part of the scale.
And then this is another way to recruit providers in here. So for example, Teresa Nielsen is looking at, she's trying to decide, does she want to be an employee mid-level, or does she want to do 1099 and be a contract? Her contract would be different than what Steve is, and as Steve said, a new grad nurse practitioner, that contract would be different also. So I'm bringing each one of those contracts to you.
Linda, just educate me a little bit from an administrative perspective. Can you just speak real briefly to advantages of an employee-based employee as opposed to a contract-based employee?
When you're talking the mid-level practitioners, they still fall under the rules and regs and bylaws of the medical staff. So when you're talking about an employed mid-level, coaching, counseling, disciplinary is a little bit different. So, and I don't know if that's what you're asking me or not.
No, that is what I'm after. I just wanted to know, like, if you're an administrator, what do you see as the pluses and minuses there?
Well, for a mid-level, it doesn't matter whether they're employed or they're 1099, they still fall under those bylaws, so I have to be careful on coaching, counseling on that mid-level. The difference between the salary, or I'm sorry, the 1099 and the employee is the employee, they have step ranges. The union has put in salary step ranges, whereas a 1099, this is what they're going to get. They're not going to get a step range.
Until they renegotiate the contract.
Their contract, exactly.
Okay.
The other side, as far as what we require of them in terms of time, can be made the same in terms of how when we do now they're employed, this is what we expect them as an employee, or this is what we expect them as a contract employee. They could be the same as far as how many days are available.
And will that be the same in this contract?
The one you have may or may not be, depending on what we expect from them.
So right now in this contract, it defines it underneath the compensation. It defines what the work hours are, what our baseline patient visits are.
Okay, and
It defines it.
Would this be the same?
Yes.
As an
Yeah.
It would be similar in terms of.
Similar or the same is not quite the same. Explain that to me, it's similar. What's the difference?
The difference is one's a contract and the other is expectations.
Well, I'm saying that the expectation is the same.
That's what I'm
Steve
saying.
Hayden, Joe up.
Yeah, I do have one comment though under the 6.3. 6.3.2A, it's on page 6.
Okay.
It says compensation after 40 hours, but then below it says hours for over 8 scheduled hours, and I think you probably want to change that to over 40 hours, to the 40 hours per week. Because if they choose to do a 10-hour days, like it's suggested they might below, then you'll be paying them $85 for those the extra 2 hours.
I see what you're saying. So put in that flexibility language, thank you. So could I have approval of that compensation rate and work hours?
And this is just for Steve?
This is just for Steve Hayden.
Okay, I would make a motion to approve that with the change that Jerry brought up.
I'll second that.
Jerry?
Aye.
Dana?
Aye.
Rich?
Aye.
Ken? And I vote aye.
Okay, so under tab G, you have the specialty care services agreement, and this is Dr. Jensen's agreement, and this is what Steve talked about specifically. And it's changing, let me find the compensation tab again. If you look on page 5 of 15, it's where we change his RVUs to 52 per total RVU, and it takes out that call time, because his previous contract, and I think the previous contract had call time in, which we don't have, 24 24/7 call. So we took that out, he agreed to that. And then we looked at our review and what we needed to do with that to compensate that. It's the same salary that we're gonna be doing with him, or the same amount, it's just different change in our review and not paying for call time. Dr. Jensen has agreed to this contract, so I'm just bringing it to the board now because it is a change.
I'm sorry, you're gonna have to educate me a little bit. I'm not tracking on call time.
So, in his previous contract, there was 15 days a month that we paid him to be on 24-hour call.
Okay.
And we're taking that out now because we don't have a surgery crew 15 days a month.
Okay.
So all you're asking is to remove that and change the RVU amount?
Yes.
Okay.
That's pretty simple. Can I have a motion?
So, second.
All in favor? Jerry?
Aye.
Dana?
Aye.
Rich? Aye. Ken?
Aye.
And I'm aye. Okay. We should be able to breeze through these resolutions, I hope.
So these resolutions, with Michael retiring, and I did not introduce Joanne, by the way, I'm sorry, Joanne. Joanne is going to be taking the executive assistant position for the CEO, so she will also be your board clerk. So it's taking Michael off, and when we put these resolutions in, at that point, Joanne was not hired, so we didn't add the board clerk in here to these resolutions.
Should she be on these?
Well, right now, when we do who's here, the only one that I think is most important is the signing of the checks,
Which one is that?
and that one's not, no, I think that's the signature card. See, the first one?
I'm sorry, where are we at now?
This would be tab H, it would be under resolution number 422.
This is SNF activities.
Okay. So these resolutions that you have before you, there would not be a need to add her on those right now. So the resolution 422, resolution 423, and 424 could be passed with how they're written. And Michael did these up before she left.
Yeah, because it is removing her. You don't need to add.
Because there's enough people on here, we made sure that there was enough
We can
people on here
add
that we
additional
really
people. We feel that we're running into trouble of finding people.
Can we vote for all three resolutions at one time? Because it's just signature cards.
Signature cards for what checks?
The first one is the signature card for the skilled nursing activities account.
Okay.
Resolution 422.
Okay.
Resolution 423 is the Plymouth Bank resident, skilled resident trust account.
Okay.
And then 424 is, that's not skilled, that's the lay funds.
It's all the hospital's bank accounts.
So none of these would be payroll checks?
No.
Okay.
Yeah. It could be Dr. Walls. The U.S. Bank is our payroll account, but
But what I want to know is, I don't want to be in a position to sign my own checks.
no, you have direct deposit. No, you actually are in a position to sign your own check because you go through accounts payable.
So what happens when that occurs is that you wouldn't be signing a check that's drafted out to you. One of the other signatories have to do that.
Okay, just so there's something in there to keep that from happening.
Can I make a motion?
I'm sorry.
Can I make a motion?
Yes.
I move that we approve resolution 422, 423, and 424.
I'll second.
Okay. Rich, I'll go in a different order.
Aye.
Dana?
Aye.
Jerry?
Aye.
Ken?
Aye.
And I vote aye.
Dr. Walls, we run into that occasionally because I may have an expense reimbursement check and I send the bulk of the things, and so it's just sent to another signer, so we don't have someone sign for their own check. No problem.
All right, this looks like a familiar subject here. And is this something that we can get through in a reasonable amount of time, you think?
Well, my question is does the board want to use the ACHD CEO evaluation that the Walker Company puts out? That's my first question. And then the second piece of it is, when we were talking about some specific criteria you wanted to see on an evaluation, the suggestion that I received from Ken Cohen at ACHD is if you're putting the CEO, whether it be me or anybody else, on an incentive program, put those additional pieces that you want to see on the evaluation on the incentive program.
Where's the evaluation committee put together?
It was still in process. There was still questions on,
It was just a matter of breaking down the percentages.
Okay.
Trying to make a distinction between evaluation and then incentive. So the evaluation before the incentive would be considered a certain score would be required of the actual evaluation.
So Linda, are you asking us to consider replacing the committee's evaluation with this one from ACHD?
yes.
And
Because I was asked to find a evaluation for the CEO, and when I sent our evaluation to the attorney, Colin copied the attorney, and I had sent the email, said that the ACHD CEO performance evaluation is what is the standard that's being used.
I like the committee put together personally. I thought it was very well done.
The
You
comments
know,
that
I just would like Linda to be able to look at these side by side, because I don't know if this is capturing some of the stuff that Dr. Walls and I were trying to capture. And we specifically had some targets in there that we would like to assure that are captured. So perhaps Dr. Walls and I can reconvene. I hate to do that, but
Good idea.
Yeah, I want to make sure this is very clear.
so
Are you reinstating the ad hoc committee then?
yeah, that's what I'd like to do, is just sit down and do a side by
Okay.
side.
I don't think you ever dissolved it.
Yeah.
What's that?
You hadn't dissolved the ad hoc.
Yeah.
We just stopped having meetings.
So I can put that finished
Yes.
one together. I'll do it for you
Just
and then
send
send
us
it out
both.
to this. Okay.
Each document, and then we can schedule a date.
Regarding the last two pages, whatever version or source that is, we do have the financial stuff now, so we can put that at least from July forward.
Okay. So then, tab L. Any questions on that? Steve, did you want to make a comment?
You know what, I have a question. My name's not Steve, I'm sorry. You want to know that?
Just, it's a constant effort to stay on top of these guys.
Well, yeah, I look at 138 denials received. That 21.5% of accounts are aged over 90 days.
It's indicative of, they continue to experience turnover of their staff, and it's probably gonna be the deal breaker with them. If they can't keep and retain staff, we just can't continue to incur this. So, it's July, or it's June. When we get to late fall, early winter, if we're just treading water here, then we're probably gonna have to look at an alternative solution.
Where are they located?
Washington State.
Do we have an alternative?
Kind of.
Kind of.
We remember how difficult build up a recognize how difficult it was.
Right?
many years to find.
It would have to get worse.
We did have a lot of write-offs, but huge amount.
Well, we had the one big one, the swing bet account got written off.
Okay.
But that's what's disappointing is we have a big write-off, but then the days don't go down because the days grew out. And mainly in Medi-Cal where we again had a turnover in their staff, so. We'll see. I mean,
Is there anything the board can do to help?
at this point,
Okay, that's a rather big report. Did you want to make an announcement about governance education?
Plymouth County's special district is putting on the Brown Act and harassment training, which is the mandatory training. So if you wanted to go to it, it's from noon to 5, and it's on August 21st, and you just need to let us know, and we can send the RSVP to Mimi Garner-Bates. So just let us know if you want to do that. And it's
Do we have any members that are required?
I need to go.
Yeah, every 2 years you have to do it, and there's online training. This is in person. They're going to give lunch. It's just in Quincy. You don't have to do online. You just sit there. You have to take a test.
Can you consider this my?
I can.
RSVP?
Thank you. Jerry, you want to go too?
I already did my online one this year.
Oh,
I
damn
don't
it.
want to do it again.
Oh, okay, fine. Dana?
Oh, I like.
You don't have to, but you could go.
I like going to Sacramento.
Oh, okay.
Is it Quincy?
This one's in Quincy.
Well, I'd rather drive to Sacramento.
Okay, I'll put the two of you down, and we'll make sure we get you down.
Okay, bylaws committee update.
We held off last month, we're waiting for the attorney to give us more feedback.
Well, I had sent that out to you guys.
The only thing we got was the original one we sent, and we said, here's a couple of things, I'll send you more.
Let me check, because Michael said she sent it, so let me check and,
I
get it out to you.
don't recall receiving anything.
Okay.
So I think we can skip it again. Dr. Walls.
Strategic planning committee update.
Yes, we have agreement with Terry Collins on what NST had mapped out. It's to their board, so as soon as we get that legal language and agreement, we can move forward with NST. So, I mean, it's positive steps, and now it's in their court to give us their legal language so we can get it to our attorneys, because you can't do anything more for parcel split until you get the legal documents. So that's where we're at.
So I'm just curious, what happens if we didn't build a new hospital? What happens to that land? It just belongs to the district then? It doesn't revert back to Collins or anything?
Only if we try to sell it. We can't sell that land to anybody else. That's to stay to the district for district property. Whether we put a new hospital on it, whether we put hospital housing on it.
Okay. All right, and I guess you can give a report.
Okay, so I'm gonna let Pat do the provider recruitment piece to start out with.
Okay.
Did you bring it? If not,
I just, not really.
Okay, well.
It's, obviously, we signed Dr. Cooper, the start date is August 5th. I'm still credentialing Dr. Scott, urologist. His estimated start date is July 8th. I can get it completed and approved by Dr. Walls. We had the PA student that was coming, and Dr. Ware was going to be his preceptor. And luckily, Dr. Mellon has stepped up and is going to precept him for the month of July. So Linda and I spoke with Tour University during this process, because he's supposed to start July 1st, so it was very short notice. And they want to definitely work on putting, they have a nurse practitioner PA rule rotation program, and they want us to definitely be a part of that. So this is like the beginning steps with them. They know Dr. Cooper is coming, and the student has another family practice rotation to do in like October. And they're thinking about if he wants to come back, work with Dr. Cooper.
Are we putting the student up somewhere, housing wise?
They're responsible for their own when they come as a student, yeah. And apparently he has some type of connection here in Chester.
Oh, okay.
So
he has a place?
Yes.
Okay, that's what I was hoping.
Yeah. And because he's going to do ED 24-hour shifts, his days will be less than if it was clinic.
Okay, thank you.
So we also interviewed
Oh, yes, I forgot that. Sorry.
shoot, where is he?
Dr.
Yosef, Andrew Yosef, he is a Canadian citizen. This would require doing the J1 visa. And apparently it's easier to get a visa for physicians because we're a rural health clinic. So the process is faster, it's not quite as bad. A J1 visa doc has to give us a minimum of 3 years, and if they like it here and we like them, after the 3 years, I need to back up a minute, they can be eligible for a green card and they can stay. So it's not like 3 years and then we kick them out and it's not like on the proposal. He can get a green card and stay. The other issue is, yes, he's required to stay here for a minimum of 3 years, but if we find that he's not a fit for the community, then we are not liable to find him someplace else to go. He has to find another place to go.
How did he find us in the first place?
Through the recruiting company. This is another piece of what I've been doing of reaching out
Very nice.
to
He
try to
wants
get
come
positions
out.
here. He wants the rural environment. He likes this type of setting. He wants to do what we have, which is clinic physician, which is in the ER, skilled inpatients. So he wants to come out for an inside interview. The drawback on him is his residency doesn't complete until June of 2020. Then we have another person that we're getting ready to interview. She's Dr. Cobb. She is expected to graduate the same time, June of 2020. Right now she's in Tucson in her residency. So we'll be interviewing her as well. Then,
Send her pictures of trees. Lots of trees.
well, we talked with,
With or without snow?
well, we talked with Yusef about it, Dr. Yusef, and he was real excited about coming. This was a physician that has been talking to us for a good 6 months about coming out, and we were a little restive about J1 visas, and then we thought, why not? Let's give it a try. Let's try to get him out here.
Where has he lived in?
He has lived in Canada and he's in Chicago right now. So he knows snow. He said snow is not a problem whatsoever.
Oh, Canada where?
Oh, Canada.
Well, I thought they,
I'm hurrying.
He can check back with you.
Okay. So, and then the last part is the 3 CEOs, we've been talking about different positions and whatnot, and we've been sharing positions. If we've got some recruited physicians who don't want to go to their area, so Todd Plimpton at Eastern Plymouth has a couple of physicians he's going to be sending our way to interview. So some help there. And then did you talk about the FNP student who's here? I think you did. The FNP student who's here now, she will be graduating and she really likes it here. She's a little worried about because we're trying to lock her into a contract. She doesn't want to do that until she passes her boards. She's afraid, and I can see her side of it too, but otherwise I'll lock her in. She wants to stay here as well.
When is she taking her course?
This is her last semester, so as soon as she finishes out, then it's my understanding she's going to sit the board right away.
She should be about done now, shouldn't she?
I think she's done in July.
Yeah, about the middle of July.
Is this Aries daughter?
Yes.
It's the pharmacist daughter.
So
She's a doctor.
No,
she's a PA.
PA.
So
Physician.
she's a-
PA, but it's
And
Harry
sorry,
Sir's
and-
daughter.
So the last one is Dr. Cooper's contract. It was within my signing authority. I brought it here to you so you could see that we didn't sign him outside of my signing authority.
Did they find a place to live?
Yes and no. Yes, they found the house that it was the rental house, or the vacation rental house, that they're gonna turn it into a monthly rental house with the lease. The problem is that house comes furnished, and the people who own it want them to vacate for a week and a half in September. So Lindsay, I think she had to leave. Lindsay's been working again with the realtors in town about finding another house. We found 3 other rentals right now that Lindsay's working with them to see if that would be more appropriate. So when I say yes and no, yes, he has that one house that we knew about, but we're looking at something that might be more suitable.
There's, Bailey Creek has houses. Would they ever, I wonder if they would ever consider, instead of doing weekly and monthly rentals, if they were offered, but.
That's what Lindsay's checking into.
Okay.
Apparently, that one of the
Great
realtors.
minds run in the same track.
Yeah, she's checking into that for us, so. Okay, the other piece under tab 0, is you asked me that when we get plan of corrections approved, you wanted to see the document, so there's that document for you. It's the relicensing plan of correction, survey plan of correction for the skill. So that one was approved. Administrative office changes, that's, I introduced Joanne, and Pat has tendered her resignation, so we will be interviewing for a med staff coordinator. The Combe family donation, we're still asking medical staff and staff what it is they would like to see for us to purchase with that $10,000. So we've not come with anything to bring to the board yet, that's specific. And then the last piece that I had is this Feather River College support letter. We had sent one out from the admin team, but they were also asking to have one from the board. So the board letter looks real similar to this one. It just has board president's signature on it to send out. So we had already, as I said, sent one out from the admin team, but Kevin Rutna suggested maybe one coming from the board would be helpful as well. So we'll get that sent out if the board agrees. And then that's all I have for right now.
Thank you.
You're welcome.
Do we have department reports? Kate, is Casey gone?
But Heather's here,
Yes.
and she's going to give a very brief report.
Well, I don't know much to say for this report. I'm doing the interim position currently where Ashley was. Casey and I have put together some QA dashboard for you folks today. She was going to be there to present it, and that's all my sick kids. So aside from that, we've been just keeping up with day-to-day stuff. Here she is.
You're up.
So, well,
Dashboard.
Casey will have a full quality report in her closed session for the board and support.
Okay. And Sadie isn't here?
Sadie's not here. We did send Sadie and Lindsay to the Flex conference, and Lindsay's not here either, so they can chat about it later or do a written report and send it out to you.
Can you tell us what the Flex
I
conference
was just going to say, what is the
It's
Flex
the
Conference?
Western Region Flex Conference, so usually the CEOs go to that. This time it was really concentrated on reimbursement, funding, and workforce shortages.
Okay. Karen? Not here?
No,
I don't think she had anything
I don't think she did.
new.
And Ashley's not here.
Ashley's not here.
Ann, do you have anything to report?
Yeah, I have a couple of things. Last board meeting, I was asked to email staff out on the no-shows and cancellations for telehealth. It ended up being a lot more complex than what I thought because every office does things a little bit differently. We don't have consistent tracking practices. Anyways, long story short, the numbers that I did pull, and I'm somewhat confident that they're
somewhat reflective of what is going on, shows that telehealth is about double the no-show cancellation policies. So I'm looking into that, seeing if what we can do to reduce that number overall. So I have those specific numbers. I can email out or I can address them now if you'd like, but we're looking at about double for cancellation no-shows on top of telehealth.
And what are you thinking in terms of ways to reduce that?
One of the providers that has the highest incidence of no-shows and cancellations controls her own schedules and does her own reminder calls. So I'm thinking we need to get more involved specifically on that to see if that makes a difference. We've talked about kind of on the backside for a while what it would take to do text reminders for patients. So I'm going to look harder into that, see if I can help move that forward or at least start the conversation. Some of it I don't think there is a possibility, because last night at 4 to 6 we talked to one patient, reminded, oh yeah, I'm going to be there, no show today. So, some of it we're not going to be able to control like always. I don't know if that's specific to telehealth, but specific to the specialty, but I'll be monitoring that more.
Can we bill for no-shows? Can we bill for no-shows?
We don't have a policy for that, but that's something that we are working on.
So that kind of goes to my question. If someone wants to control their own reminder schedule, make those calls as opposed to us doing that, who bears the financial loss in that situation?
So the nice thing with that provider is she doesn't bill us for cancellations. As long as there's a cancellation for 2 minutes before the appointment, she doesn't bill us. It's the no-shows that they bill us, which is a small portion of their fee. So that's what we need to look at and track and see what that is.
That'd be good.
So other than that, I did have some really good news last night also. I've been working for a while, and I talked about it probably 6 months ago, if not longer, about our telehealth contract with Renown and using their specialty providers and the roadblock that we aren't able to send our Medi-Cal patients over there. I talked to California Health and Wellness yesterday, and they confirmed that they have a contract in place with Renown, and they are letting us send our specialty or our patients from California Health and Wellness to Renown going over state line. And they are those providers at Renown are also able to prescribe to any pharmacy that the California Health and Wellness is prescribed to. So we can really open that up, and we can see we can either send them in person or see them here via telehealth, which I think is really amazing for our practice and our community.
It is.
So that was it.
Thank you. TK, did you have?
I don't have any conclusion.
Okay, thank you. Jacob?
I just have a couple things. Touching on the telehealth bid, we have received our new telehealth card for Renown. We will be implementing that early next week. It is a brand new card to be able to start to screen on. Hopefully it'll be much better, so we'll get card eligible for having everything else back up and running. We completed our printer change out over the weekend. It went relatively smooth. We've been in production for about 4 days and not a lot of complaints or tickets. Everything's was all secure printed now. All goes to a central server. It sits there until you swipe your barcode badge as a printer, and you can release your printout there. So we have no more cost contamination of billing, factory, other services, all at the same printer, saving computers trying to find paper printing. And lastly, our biannual third-party audit for security and IT programs and policies will be kicking off in July.
Thank you. Jim?
Am I up? I'm just checking on a couple of dates for the healthcare, because Lindsay's not here. So as far as you've got in front of you what we've got a few new housekeeper. We have some per diems in the diet, in the dietary. We have a new staff RN who's a per diem. Hopefully she'll move into more part-time or full-time as time goes on. And we also have a radiologic technologist full-time, which kind of fell into our laps. And she will take the place of the traveler that we've had here, so that will be good for the X-ray department. We're still gonna pursue a third one full-time as well. As far as conditional offers, we've been pretty busy. We have a medical receptionist, 2 LVNs that are new grads from the Lassen College program. They're already signed up with the Alliance for Workforce, so we're moving forward with them, and hopefully it's gonna start on July 8th. If the Alliance is ready to go, so we'll be. Again, the 2 occupational one's occupational therapist, the other is occupational therapist assistant. We anticipate, like Steve said, a 7/15 start date on this. And we have lost 2 employees, one through retirement and the other on a probationary discharge.
Okay, thank you.
Oh, and the healthcare, probably Lindsay would have said this, and I'm gonna check my days, because it's the 7th and 8th of July and the 16th and 17th of July. It's Tuesday, Wednesday, so I was just checking to see. 9th and 10th, I'm sorry. Yeah, 9th and 10th and 16th, 17th, thank you.
And it's off campus again.
It's off campus, correct, behind the wellness center.
We have nothing for the consent agenda. Agenda items to be added to next month's agenda. The only note that I made was that Ken had requested a closed session to discuss some confidentiality.
Right, or we'll get with the attorney to find out to that revision.
Okay.
I think I'd like to add this Senate bill, was it Senate 58? Some kind of, we get some more detailed information
Yes, you can.
about that.
We talked about 31 new requirements or something.
Okay, then we'll take a quick break and then the board will meet in a closed session.
I've heard several times.
I was worried about ours, because our agent didn't
Ready?
but
We're back in open session, and I'll report that the board met in closed session to discuss the QAPI for the last 4th quarter and this 1st quarter, and we also discussed a potential case of anticipated litigation. And I'll accept the motion now.
I move that
We get to send the reservation of rights letter to the Beta that will cover Seneca Healthcare District, Linda Wagner, and Does 1 through 25 inclusive.
Is there a second?
I'll second.
In favor? Jerry? Dana? Rich? Ken? And I'm aye.
Sorry, I missed who made the motion in a second.
Rich made the motion.
Ken second.
Okay, and the next regular meeting will be July 25th, is that right? It's in here? Okay, and I guess we will adjourn.
Thank you.